Hi everyone, I'm Dr. Pushkar Dhir from Dhir Hospital, Bhiwani, and today we have a live surgery or a deferred live surgery on this 62-year-old gentleman who is a retired businessman by profession, and we have planned a Rayner GMV IOL for him, and we will be targeting right now the first near zero refraction for him, and later on, since it's a bilateral cataract with NS2 cortical grade and some amount of PSC, we have planned to do a mini-monovision for such cases. Right now, the current readings for this case is approximately the K1, K2 are with steep axis of K2 at 180 degree and a cylindrical of 0.25. And the Rayner EMV will be putting in this case. I'll be operating on a Hack Street microscope with a Legion machine, and these will be my settings. So depending on the start of the surgery, I'll decide for either I'll go for a direct chop or maybe a divide and conquer. So now we'll start the surgery.
बाबा जी सीधे लाइट में देखना है, बहुत अच्छे. शुरू करेंगे ऑपरेशन. So I will be doing a cataract surgery in this case, and I will be doing a temporal phaco. I usually make my side ports at 12 and 6 o'clock, and the main port would be somewhere near the steeper axis, which is approximately 174 degrees, so as to negate the 0.25 cylinder which we saw on the keratometry. हमने देखते रहो, बहुत अच्छे. Okay. So in most of my surgeries I use Blurex, except in the cases where we have only PSC type of cataract. This is nuclear sclerosis grade 3 with cortical and PSC cataract. And बाबा जी सीधे देखो एक बार, सीधे सीधे. हाँ. I'll be stabilizing my globe with the help of McPherson and continue my rexes with the help of cystitome, that is 26 gauge needle. The rexes which I am going to make tend to make around 5.5 to 5 mm, and it's mostly the centrifugal force which I am using right now to make my rexes round. And I've come temporally, and now I am going superiorly. It's mostly the centripetal force which is acting right now. So my rexes is decently circular and is complete. I'll be making a temporal main section. I'll be using a 2.8 keratome, though the lens which I am planning to use, that is Rayner EMV, has 2.2 cartridge system. Rather, Rayner IOLs across the platforms are preloaded with the injector system of only 2.2. So you don't need to enlarge the section while you insert your IOLs, like in many other companies we see this problem. So now I am done with my hydrodissection, delineation and the rotation of the nucleus. Mostly it's a free nucleus, so Scott. बाबा जी सामने हिलाओ मत प्लीज, लाइट में देखते रहो. फिक और चॉपर रेडी करो. So I'll be doing a direct chop, and I'll be using a vertical chopper. So सामने देखो, सामने सामने बाबा जी सामने देखो. I'm doing my pre-chop as of now. Pre-chop. Now I'm engaging the phaco in the nuclear bed itself. And the first vertical chop is done. So I take my chopper slightly far, but it's definitely not the horizontal like we have seen in with the terminal chopper itself. Mine is more of a vertical chopper and slightly angled. So I am dividing the nucleus into multiple segments. As I eat, as my machine takes up the nucleus itself, so I'll say something about the IOL. It's the Rayner EMV IOL. So EMV stands for the Enhanced Monovision IOL, and it is the only IOL which has a positive spherical aberration in it, and that too very smartly planned. That positive spherical aberration is only at the central part. So I am done with my phaco, and now I will be doing bimanual. I will be doing the cortical removal with bimanual. I find it very safe. While I do my eye, I will talk about the IOL itself again. So as I told you, it has a positive spherical aberration, and that too at the center. our cornea per se has a spherical aberration which is positive, and as we age, our lens also gets spherical aberration in the positive only. So most of the time we land up with the putting negative spherical IOL, thinking that it will neutralize the net spherical aberration present in our eye. No doubt it is one of the way to treat our eye's aberration, but creating a net zero aberration creates a good contrast, while slight of positive spherical aberration, that too in the central part, will actually increase the depth of focus. And that is what the principle of Rayner EMV is. It takes care of the 4th order and the 6th order aberrations, and the cornea lens system, the natural lens system, as we age is totally positive, while the cornea IOL system is what we can plan. We can either plan it a net positive or a net neutral or a net zero also. So that is what we can plan in it. So if you are practicing monovision or per se the mini-monovision, you can actually play with your biometry itself, keeping the dominant eye as with a refraction of 0 and the non-dominant eye slightly myopic. We can have more than just the intermediate, we can actually have the near vision also. So it depends how you are playing with your biometry while you operate. So now I'll be demonstrating that how the visco needs to be injected in the cartridge of Rayner IOL. It's a preloaded lens, so there's a small opening on the top of the lens. You can just fill in with the visco and click the cartridge itself. We are almost ready to insert, though I use a hydro insertion in most of my cases, but just to demonstrate in this case I am put viscoelastics inside the AC of my eye. So regarding the IOL, again it's a very soft IOL with just 2.2 mm of insertion. It opens very nicely without any delay, and the haptics, I have never seen them getting stuck or engaged in the cartridge. It is literally flawless. The IOL per se is made up of the raphilic material which has a good water content, but the surface itself is hydrophobic, and that's why the PCO rates are less in EMV. The optic haptics are designed that way that in case of toric IOLs, haptics only take up all the pressure forces coming from the in situ bag implantation, and it doesn't transmit to the optic, and there is very good rotational stability with the toric IOL. So as I complete my surgery, just a word about the contrast and the modulation transfer focus curve. So when we compare the MTF curve, which companies keeps us telling, the EMV has a very broad MTF curve as compared to the others like Technis and iHands, giving it a slight edge over for the intermediate vision. And if you practice mini-monovision, you can actually have a near vision also. And it has a good FV number, that means there is less of chromatic aberration. So when company people come and tell you that we have a negative spherical aberration or a positive spherical aberration, try to understand your patient and the last thing you want to attain, then only plan your IOL. Beta din dal do. With that, thank you so much for watching my surgery.